So just going over some basic definitions. You know, I think that sometimes when you look at medical terms, they can be sometimes confusing to most people. And oftentimes it's because a lot of times the names for things are actually not very good names if you actually break down the meaning of the word. So arthro, who knows what arthro means? Huh? No, arthro means joint. So like an arthropod is like an insect that walks on its joints. So arthro means joint. Itis, I-T-I-S, the suffix. Who knows what itis means? Inflammation, exactly. So inflammation. So arthritis means inflammation of a joint. But the problem is that most of us that have arthritis don't have inflammation of their joint, yet we have arthritis. So it's actually a bad term. A better term for it actually is degenerative joint disease or chondromalacia. And again, if you break the word chondromalacia down, chondro means cartilage, mal means bad, just bad cartilage. That's really what arthritis is. But there are two big categories with arthritis, inflammatory and degenerative. And so they're two distinct. The most common out of the two is degenerative, which is the most common. 90% of all people with arthritis have degenerative arthritis, where only about 10 to 15% of us have inflammatory arthritis. And again, you can see with the inflammatory arthritis, there's a whole host of different types of inflammatory arthritis. So inflammatory arthritis, by definition, means that something's causing inflammation within the knee that causes it to be swollen and painful. Now, people with degenerative arthritis, again, not to be confused, can have sometimes inflammation within their joint and have swelling. But again, they tend to be two separate things. Bursitis. So how many people here know what a bursa is? One? Two? All right, so bursa are fluid-filled sacs that we have all over our body. We have hundreds and hundreds of bursa. Around the knee alone, there's at least 15 named bursa, and there's probably more than that. What bursa are fluid-filled sacs that act as a cushion to help protect sensitive areas, but mostly to protect where our tendons attach to the bone. So when our tendon pulls on the bone a little bit too much, the bursa becomes inflamed and tells our brain, hey, we better stop that or we're going to rip that tendon right off the bone. So it helps protect us from having tendon ruptures and tendon tears. So bursa are very important. But sometimes when they become inflamed, again, bursitis, I-T-I-S, means inflammation of, it means inflammation of that bursa sac. So these are some definitions. Next. So arthritis, when you start looking at arthritis, there's a whole bunch of things that we look at, and this slide is actually comparing the two main categories. One being osteoarthritis or degenerative arthritis, the other one being rheumatoid arthritis or inflammatory arthritis. And these are some of the things that we look for on x-ray that help me as a physician to determine which I think is going on with your knee. You know, is this an inflammatory process or is this a degenerative process? And some of the things that you see here, cartilage begins to break down. It almost looks like little cracks in the concrete if you look at that, and sometimes when you scope somebody's knee, you can actually see those little cracks, or what I call fissures. You have sometimes little cartilage remnants, in other words, it starts breaking off like little pebbles. When they break off and they become big, we call those loose bodies. And that's kind of like the analogy of having a rock in your shoe. You know, when you have a rock in your shoe, it can be pretty painful when it gets in the wrong spot. Well, imagine that in your knee. And some of you may have had a loose body in your knee. And it can be extremely painful and cause your knee to prevent it from straightening out or bending it. So arthritis itself can cause these problems. When I look at the x-ray, there'll be narrow joint space and oftentimes bone spurs, which interestingly, with inflammatory arthritis, you don't see bone spurs. The thing with inflammatory arthritis is that oftentimes, like for example, rheumatoid arthritis, it's our own immune system starts attacking the lining of the joint. So the lining of the joint itself, the body perceives it to be an infection, so it brings all these inflammatory cells, and then people have heard of synovitis. Have you heard of synovitis before? Synovium is the lining of the joint, so again, you add I-T-I-S at the end of synovium, synovitis. It means inflammation of the lining of the joint, and that's what you see with somebody with, for example, with rheumatoid arthritis or psoriatic arthritis or some of the other inflammatory arthritis. When I look at an x-ray, you actually don't see bone spurs. You'll actually see the bone actually looking weaker and weaker because of the inflammation around it. So again, from an orthopedic surgeon's perspective, just by looking at x-rays sometimes, I can tell what type of arthritis you have. Next. So when we start talking about the stages of arthritis, particularly osteoarthritis, because that's where the focus of this talk is going to be on predominantly when we talk about arthritis, because it's the most common. 90% of us will get osteoarthritis somewhere in our body. You have 4 stages. You have first stage, second stage, third stage, and fourth stage, and 4 being the most severe, 1 being very minimal to none. And that's really the 4 stages. So if you ever hear your surgeon or doctor say, oh, you have got stage 3 arthritis or stage 4 arthritis, that means you're in the moderate to severe range. Next slide. So there are things that are in our knee that helps protect it, and somebody who is a sports medicine doc as well as a knee specialist and takes care of the knee from 12-year-olds all the way up to people that are over 100 years old, I can tell you that arthritis, interestingly, sometimes starts in childhood, starts in the teenage years. And the meniscus, there are 2 of them, one on the outside called the lateral meniscus, one on the inside called the medial meniscus, are the cushions or shock absorbers of the knees. And oftentimes with a sporting injury of pivoting, twisting, the foot's planted, you don't really feel a pop. When you hear a pop, usually that means a ligament was torn, but usually it's a twitch, and the person can still run, they can still think, but their knee doesn't feel right. Those are the classic symptoms of meniscal tears, and typically most people that present with meniscal tears take 1 to 2 weeks time before they come to see me. And they come to see me because they can't straighten out their knee, they can't bend their knee, or they just get sharp intermittent pain anytime they squat, pivot, or twist. Anybody can get a meniscal tear, and it doesn't always have to be a sporting injury, but especially for my young people that do it, it tends to be more of a higher energy because the meniscus is much more bad word, more pliant, and more like rubber. Then as we get older, it becomes more brittle and more prone to tearing. But that helps protect our knee. And if you look at a normal knee on the left and then you look on the right, that's what happens when meniscal tears occur and cartilage erosion occurs, and then it starts to affect the bone. Next. So here you can see different types of x-rays. You have osteoarthritis here on this side. One of the things you see here, it's kind of hard, it's a little blurry, but big bone spurs, just about bone-on-bone arthritis. When you look at the rheumatoid arthritis, it tends to be more, see how the bone's modeled, like it's whiskering away? You still have bone-on-bone arthritis here, but when I look at those 2 x-rays, it's obvious to me which person has rheumatoid arthritis and which one has osteoarthritis. Both of these examples, though, are very bad. These are stage 4, both in the severe range. Next slide. So talking about a little bit about bursitis. Again, here these cartoon pictures just basically show 3 bursa in the knee, but let me assure you there's over 15. But these are the most common bursa that become involved. Suprapatellar bursitis is usually right above the kneecap up here. Sometimes people with a little bit of our quad muscle is our muscle that attaches to the top bone here, our kneecap. Sometimes you can get bursitis there, and it's basically trying to protect our body from tearing our quad muscle off the bone. So that can become inflamed. Prepatellar bursitis is the most common, pre meaning before, and again, patella meaning kneecap. Bursitis is in the front of the knee, and I see that's probably the most common bursitis I see around the knee, and that very, very commonly happens with people that are like carpenters or people that put down floors or carpeting. They're on their knees all the time, but it can also occur from trauma. People can fall directly on their knee and develop an inflamed bursa right off the get-go, and that can be very painful and persist. And then infratellar bursitis is infra meaning below, it's below the kneecap, it's right here. And I see that very commonly in people that play sports like basketball or jumping, volleyball players, things like that. Again, it's protecting the patellar tendon from rupturing. Next slide. So this picture, again, it's a little bit hard to see, but this is a prepatellar bursitis. This is a knee, believe it or not, and it's just really markedly swollen. And if somebody were to come into my clinic with that, I would offer them basically a needle to drain it and drain the fluid, and maybe put a little bit of cortisone in there to get this to heal. Next slide. So a couple of things that I think that applies to everybody when we talk about knee pain. I think that there's always going back to the basics. When somebody first comes into me and says, geez, doc, what can I do to make my knees better? I think it's, some of this is common sense, but some of this is not common sense. You know, I tell people, you know, avoiding obesity, it sounds easy, but now that I'm in my mid-50s, I can tell you it's not easy with the American diet. And the older we get, the more our metabolism slows down, and the harder it is to keep off the weight. You know, what we normally could eat when we were 20 to 30 becomes very difficult when you're 50 or 60 to keep that weight off from happening. But keeping the weight off is important. You know, I had a patient the other day who was 32 years old and weighed 550 pounds. She had incredible pain in her knee, and she was already developing severe arthritis in her knee. And I said, well, imagine if I was carrying myself, I weigh 200 pounds on my back all day long. My knees, my back, my hips are going to ache, and sooner or later they're going to wear out. So avoiding obesity is easier said than done, and sometimes some of us need help with obesity, and seeing a dietitian, a nutritionist. You know, I've tried every diet on the planet. I've even tried the keto. How many people have tried the keto diet? Anybody keto? Have you heard of the keto diet? So it's kind of like the Atkins diet. It's high fat, high protein, no carbs or very low carbs, and it works. But the problem is it's not very good for your heart. so you know, you're robbing Peter to pay Paul. So I really believe the best diet out there is the Mediterranean diet, where it's very colorful vegetables. Protein is gained by fish, chicken, things like that. And having a balanced diet, I think, is easier said than done. But and fresh food with no preservatives, I think, is the best thing. So that's that. Body mass index. We're not going to talk a lot about that, but a lot of times people will talk about, you know, what your BMI is, and that's the way they'll calculate what your weight should be and ideal body weight should be. I tell people weight loss is possible. It is like a disease, and sometimes you have to treat it like a disease. And sometimes that means seeing a nutritionist, seeing a physical therapist, a trainer, and determining what you can and cannot do. I mean, there's nothing more frustrating to me now that I'm in my mid-50s to buy a video and see this 29-year-old, you know, doing all these workouts and getting in shape and doing 1,000 push-ups, 1,000 sit-ups, and they look great. Well, that doesn't apply to me anymore. Maybe when I was 29, but that doesn't apply to me anymore. So there's ways to stay fit and stay active that is more commensurate with your ability at this phase of our life. Diet supplements and preservatives, again, we talked a little bit about that. And getting active, I think that, you know, I have, like even this young gal that I saw that was 32 years old and obviously morbidly obese, I told her, I said, you need to lose the weight. And she says, well, I can't exercise. My knees, my back, my hips hurting too much. So you get into a pool. And water aerobics is something that everybody in this room can do. You don't even have to swim to be able to do water aerobics. But getting into a pool, the buoyancy of the water decreases any loads you put across your joints. The resistance of the water helps tone up your muscles, burn fat. And I have not known one person who's done water aerobics that didn't come back to me and tell me, you know what, it was great. I made new friends, people just like me going through similar issues, similar problems, and it turned out to be some of the best advice you've given me. And I've had some patients, I just saw a patient this morning who lost over 100 pounds this past year, not from last year, 2018 till now. And I couldn't believe the difference in this person who just basically got a nutritionist, the diet, got involved with the YMCA, started doing some low weights and doing water aerobics, and lost the weight. And he looks great. And now he doesn't need to have his knees replaced because he's doing that well. His knee pain is getting better. So next slide. Kneecap pain is probably the most common problem I see of all my patients of all ages. The kneecap is, in medical terms, we call it a sesamoid bone, in that it's actually within two tendons. It's actually the same tendon. The quad tendon comes down, it attaches to the kneecap, and then the kneecap has a tendon that attaches to the bone. So what's the purpose of the kneecap? Well, the purpose of the kneecap is it acts as a pulley, and it actually decreases the force needed to straighten out our leg or slow down our knees. So without a kneecap, people's knees buckle, they wobble. You can walk without a kneecap, but it's not the same thing. So having a kneecap is very important. But because of different shapes, you know, people with wider hips or people that are knock-kneed are more susceptible to kneecap pain. Sometimes people have had previous injury or trauma are more susceptible to it. So, most of the nerves in the knee are around the kneecap. So that would also explain why it's the most common problem that I do see in my clinic. So it's a very common problem. And going up and down stairs are classic findings. Popping, grinding. If you're sitting down and you go to straighten out your knee, you hear pop, 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 pop. That's most likely your kneecap that's making that noise. Not your arthritis on the inside or outside of your knee, but the arthritis underneath your kneecap. Knee arthritis, classic symptoms are stiffness with inactivity. Many of you here sitting for the next half hour to an hour, go to get up, you may go, oh my gosh, that first step or two, and then once you get going, okay, I'm good, everything's all right. That's classic arthritic symptoms. Cold weather, rainy weather, barometric pressures cause pressure changes in our knee, and it can really affect the achiness and stiffness associated with that. And then, of course, the swelling. If you have arthritis, as the day goes on, the knee starts to blow up and gets more and more swollen. And bursitis, again, tends to be swelling that's in one located area. It tends to be sharp pain, and it tends to be tender right when you push on it and touch it. Next slide. So management. Everybody has heard the acronym RICE. Have you heard all that? So rest, ice, compression, elevation. Anytime you have any injury or any problem of any joint, that should always be your first line of treatment. And it works for the majority of our problems. Medications, NSAID stands for non-steroidal anti-inflammatory drugs, and those are the Motrins, the Aleve, the Advil, those kind of medications, and then there's prescription medications for that. Steroids can be very helpful, sometimes oral steroids. If anybody's ever been put on a med-dose pack, I've heard of that. It's basically an oral steroid when you really hurt all over, or you had a sniffing problem, and regular NSAIDs aren't helping. Sometimes oral steroids can be very helpful. But the danger of steroids is that, like all drugs, they have side effects, and as a bone specialist, the biggest problem that I see with overuse of steroids is it can cause your bone to die in your hips, your shoulders, and in parts of your knee. So steroids do have some dangers. True story, the youngest patient I ever did a hip replacement on was 13 years old. And she had juvenile rheumatoid arthritis, and her rheumatologist put her on high-dose prednisone for a year. Well, it made her rheumatoid arthritis feel better, but what it did is it caused the bole portions of her hip to die, and she had no hips. So she had pain just sitting. She couldn't get up and walk without severity of pain. And with a 13-year-old young girl, there's only really two options when you don't have your hips. To fuse her hips, so her hips are fused, so she'd walk like this, would make maybe having relations very difficult, never mind ever having a child or bear a child, impossible, or do hip replacement surgery. And so this is a conversation I had to have with her young parents about what their options that they have to decide for a 13-year-old to have. Well, I did her hip replacement, and 2 weeks later, when she went to have her stitches removed, she said, okay, I'm ready to have my other hip replaced tomorrow. And I did, and I replaced her other hip. And as far as I know, that was when I was in Texas. She's still doing very well to this day, and that was over 20 years ago. So age is a relative contraindication, but steroids, like all drugs, have potential complications. Probably the safest medication out there that you see is topical medication. Topical medications tends to be the safest because there's not as much systemic absorption, and you don't see a lot of side effects of it. Tylenol, recently, only in the last 5 years, 6 years, we actually learned as physicians how Tylenol works. When I went to medical school in 1987, we had no idea how Tylenol worked. Tylenol had been on the market for 30 years. It's a COX-3 inhibitor. There was no such thing as a COX-3 enzyme. We didn't even know that existed. So it crosses the blood-brain barrier and inhibits COX-3, which is a type of pain enzyme, but also a temperature enzyme. So it can affect temperature and bring down fevers. So even though we knew that Tylenol worked, we had no idea the pharmacology behind it, what enzyme it was working on. So that's very interesting. Nowadays, that would never pass the FDA. But Tylenol now we know is also much more toxic to the liver than we used to think. Not too long ago in the 90s, it was uncommon for me to prescribe 3 to 4 grams of Tylenol a day for some of my patients, thinking that it was one of the safest medications out there, only to find out that it can cause liver toxicity. So every medication has side effects, and anytime any of you are put on a medication from your doctor, always ask them, what are the potential side effects? What are the most common? What is the most likely side effects I'm to have? And are there any drug-drug interactions? Well, as a physician, I can tell you it's almost impossible for any physician to know every drug-to-drug interaction, but that's very important. So when you go to your pharmacy and they ask the pharmacist, if you have any questions for the pharmacist, say, can you please look at my drug list, enter everything into the computer, and the computer nowadays will tell you all the potential drug-to-drug interactions. And when I'm in the hospital writing prescriptions, I get warnings of different drug-to-drug interactions that I may not have known about, they'll automatically come up and tell me as a physician. So this is where electronic medical records and computers have really revolutionized my practice, as far as safety, and safety is concerned with medication. And time, and I tell people, do not wait too long to be seen. And I think one of the questions I get from a lot of my patients is, or even people when I give talks, is, when should I go see the physician? When is the right time to go see the physician? And I think a couple of things. Number one, if you're having significant pain that's interfering with everyday activities, you need to get seen by a physician. I think that if you have an injury or trauma and you do the RICE and you give it a little tincture of time, usually 3 to 4 days, and you're still having persistent symptoms that's making it difficult to do everything, get seen by your physician. In my career, I've had probably now 7 people that have actually walked into my clinic with a broken leg and broken hip and broken knee. And so it doesn't pay to be tough because they all displaced their fractures, and ideally they could have had them repaired or fixed before, or not even need to be fixed if they were just been casted or splinted. And then now that they were displaced, I needed to fix them. So there's no medals for people that are putting up with severe pain. If you have severe pain, get seen. If you have questions or problems, get seen. I think that too many of my patients wait too long to get seen by a specialist. Next. So what are the treatment options that I generally offer my patients that kind of separate me from your primary care physician? One of the things that I will see when I see a patient is oftentimes I would get an x-ray first. It's one of the few times you see a physician and you get an x-ray first because I want to make sure there's no broken bones. No broken bones, now I can breathe a little deeper, and now we can go down the treatment algorithm for arthritis or whatever ails you. Cortisone can be very helpful. It's an intra-articular steroid injection. It's been around for over 50 years, and it can be very effective in the treatment of the symptoms associated with arthritis. It does not stop or prevent the progression of arthritis, and it does not reverse arthritis, but it can certainly help with the symptoms of pain and inflammation. Viscosupplementation is basically a fancy word for gel injections or lubrication injections. There's a whole bunch out there. The first one that I used over 25 years ago was called Synvisc. It came from rooster foods, and people used to call it the rooster shot or the rooster shot, and it helped lubricate the joints. It can be very effective for people with mild to moderate arthritis. Studies have shown that it's not very effective with people with bone-on-bone arthritis, so I no longer offer that. Unfortunately, my insurance plan, and maybe some other people's insurance plans in this room that have Blue Cross Blue Shield, no longer approves gel injections for people even with mild to moderate arthritis, because unfortunately they took the one study that showed it wasn't effective for severe arthritis and applied that to everyone with arthritis in the joint. So unfortunately, as I get older, insurance companies are having more and more say with regards to what intervention can be implemented or not, and this is one of them that is somewhat frustrating to me. The next two are deemed by the FDA to be experimental. Platelet-rich plasma basically is when we take blood from your arm, we spin it down in a centrifuge, and we take growth factors from your own platelets, we concentrate them, and we then inject your growth factors into a tendon or into a joint, and it's to help heal and regenerate. Studies have shown that PRP injections can be very helpful with people with tennis elbow. If anybody here's had tennis elbow, extremely helpful. And I've used it for people with, again, mild to moderate arthritis, and I have had, so far, since 2016, some pretty good results with it. Stem cell injections are all the rage. You'll probably go online or Google it, and you'll see all these accolades about stem cells this, stem cells that, stem cells this. 3 years ago, if I was giving this lecture, you would have heard me really excited about stem cells and say, wow, this is where medicine is going, it's the next greatest thing. The problem is there hasn't been a lot of good controlled studies, and when we look at studies, we have level 1 through level 5. Level 5 is like an expert opinion. A level 4 study is a retrospective looking back Level 1 is a double-blinded study where the doctor and the patient doesn't know what they're getting. Those tend to be the best studies, level 1 studies. So there hasn't been a lot of good level 1 studies looking at stem cells and the efficacy of it. And really, we don't know if we're giving the right amount, how much we're giving, the timing of it, who should be getting it, and who shouldn't be getting it. But I started offering it back in 2016 because I think it is still potentially the future of medicine. I think regenerative medicine is in the future, but it's still, I think, right now in its infancy at this point. Next slide. So unloader braces, I have this slide only to tell you that although I do prescribe unloader braces, I prescribe them only to people who really want them. I don't think they really work that great, to be quite frank with you. If you look at your shape of your own leg, your thigh tends to be bigger than your calf, and no matter how you design the brace, gravity has an effect and the braces tend to slide. Also, to get it on tight, they tend to sometimes be uncomfortable. If you're bow-legged and unloader brace, you're trying to unload the area that you have bone-on-bone arthritis, so the goal is to straighten out your knee. Well, to straighten out your knee with the brace hurts, and it hurts to leave it on. So 10 to 15 years ago, I used to prescribe a lot of unloader braces, and then when I started really inquiring with my patients, where's your unloader brace? You're coming back to see me for your knee, and then they kind of looked sheepishly at me and say, well, it's in the closet collecting dust, you know, and that's what a lot of them. So I'm not a big fan of unloader braces unless people are really interested in it and are definitely opposed to surgery and would like to try it. I think it's reasonable to try, but I'm not a big fan anymore. Bursitis, we oftentimes drain it and put a little bit of cortisone in it, and that can help tremendously. Next slide. So when I start talking about surgery, when do I really, what are my indications for surgery? And I think that, you know, the vast majority at the beginning of this talk, we talked about all these non-operative treatment options. And I think really failed non-operative management, I think is to me probably the most important indication you can start considering surgery. I think interfering with your activities of daily living and your quality of life is also very important. You know, I've had a patient who just came in today. She said basically, I've been playing tennis my whole life. 72 years young. I want to play tennis well until I'm in my 80s. My knee now is limiting me. I've had shots. I've had this. I've had braces. She's ready. She's ready to have her. Can she walk? Sure. Can she walk from here to the end of this room without a cane? No. Does she try to? Yes. But she wants to stay active. So I think that happens. And then the last thing that my rule of tens. This is something that has really come about over the last, I'd say, 8 to 9 years for me. The first two things were really the only two criteria I used to indicate somebody for surgery. And my rule of tens now is anytime somebody has 10 degrees bowed knee, 10 degrees not knee, they lack 10 degrees of extension or they lack 10 degrees of flexion, I'm going to strongly recommend that you have surgery. And the reason for that is when you do, for example, a knee replacement, the goal is to straighten out the knee, to straighten it. Well, I had one patient who had his leg basically almost amputated from a car hitting him and pinning him up against the wall. And he had his legs basically sewed back on. Well, 10 years later, he came back to see me, and he had only 30 to 60 degrees range of motion. 30 degrees this way, 60 degrees this way. That was it, just a little bit of motion. That meant he couldn't sit on an airplane seat. He couldn't sit in an old movie theater, not the new ones where you can stretch out and lean back, but the old ones. And it really limited the quality of his life. Well, he waited 10 years to come see me, and when I did his knee replacement, he had 0 to 90 degrees range of motion, but what was limiting his ability to bend his knee was his quad muscle. His quad was so scarred in, it couldn't bend any further without tearing it. So that's all he got. So technically, he was considered one of my poorer results because he only had 0 to 90 degrees after I replaced his knee. But if you ask him, he was super happy that he had it done. He just wished he had it done earlier. So what's most predictive of preoperative motion, what's most predictive of postoperative motion is your preoperative motion. So people that start losing motion, you're putting yourself at risk for not having an ideal outcome. The other thing that can happen too, I had a patient the other day who had a 45-degree bowed knee, and when I straightened her knee out, she developed blisters because the skin stretched, just by straightening her knee out. 45 degrees is significant. So by straightening her knee out, and she did fine, and the blisters went on to heal, but of course, I get gray hair because I worry about infection. You know, those blisters worry me because now they're open, potentially stores for bacteria to hop on the bandwagon and cause an infection. So again, my rule of tens is now one of my indications to consider doing surgery. Next slide. So, clinical outcomes. One of the things that you may hear about as far as statistical analysis is something called the Quality for Adjusted Years of Life, QALY. It's a statistical analysis that they're going to use more and more as time goes on, and as funding for Medicare and Medicaid continues to shrink. The government or any insurance agencies have to start looking at where do we get the most bang for our buck in society for surgery or surgical interventions. And when you look at total knee replacement, it's 15 times greater, statistically better for you than even cardiac bypass surgery. So you're more apt to have your knee replaced and live a better quality of life than have bypass surgery and not have a better quality of life. The #1 surgery in the world for that meets this criteria, that's even better than total knee replacement, who can guess? What do you think would be the #1 best surgery that you can have for society? You know, cataract surgery. Eye surgery, so not being able to see is actually more important for your quality of life than even being able to walk. So, but hip surgery is also up there in the top 10, hip replacement surgery. So, I think that in the last 15 years, 16 years of being in private practice, I can tell you that my results back in the early 2000s have gone from 85% good action results to 90% good action results. And why the significant improvement? Well, because of technology. Technology has really improved a lot of things. In 2007, I started using computer navigation in the operating room, the computer in the operating room with me, giving me information, telling me what the computer thinks I should be doing. You know, I thought that would be science fiction in 2003, but boy, 2007, 4 years later, being in private practice, here's this computer in the operating room telling me what to do, basically. And in 2009, I switched companies to Stryker, who's here tonight, because they just had a much better platform. The first the first computer I used was actually designed for neurosurgeons, and it wasn't really designed for orthopedic surgeons, and therefore there was a lot of problems with the software, a lot of problems with the design, and for example, mapping out the knee and mapping out your knee in the operating room. If I didn't like a point, I'd have to redo everything with the old system. With their new system, if I don't like a point, I literally go back to another point, and I don't have to redo anything. So it actually saves me time in the operating room doing it. So that's one of the reasons, one of the many reasons. I think the other reason that's really helped is getting specialty teams, like I mentioned earlier. Having a team around me that literally I did 5 knee replacements yesterday, and not once did we talk about what instrument to hand to me, not once did we talk about you know, this or that. The whole team is just like clockwork, and everybody's talking about usually something else, like what they watched in the movies last night or something like that. So it sounds crazy, but when you're that good and you have that team surrounding you, you know, you don't need to talk about this next step or this next step. They already know. The staff already knows the next step, which really makes my job much easier. The other thing that I think that is really interesting is that when I do joint replacements, about 9 years ago, I started offering people 2 weeks later to do their other knee. And people say, boy, you're crazy. No one who has a knee replacement is going to want to have their other knee replaced 2 weeks later. Too much pain, too much this. And there was the busiest orthopedic surgeon in the United States was down in Florida, and I went to visit him, and I asked him, I said, well, how does he do it? And he said 2 weeks seems to be the ideal time, because you can take advantage of the second anesthesia, you can take out their stitches, you can actually move their knee, break up any scar tissue that may be developing, and 2 weeks is right about the right amount of time that they're ready to have their other knee. They may not think it the first week, but by the second week they'll be ready. So I started offering that, and now I would say, like what, about 70, 80 patients a year, something like that, 70 to 80 patients a year, I probably do it that way. And out of the people that sign up to have their other one done, I have maybe 2 cancellations a year of the 70 people that sign up to have their other one done. So this is really what I'm excited about, how technology has really evolved and actually revolutionized my practice. Since 2007 to 16, I started doing outpatient knee replacements. If you were to ask me even 5 years ago, would I be doing outpatient knee replacements, I'd say that's fiction. But now I'm doing outpatient knee replacements, and those patients, I want to say 5 of them, 2 weeks later chose to have their other knee done as an outpatient. So 2 to 3 hours. I can tell you that I'm old enough that in the early 90s, we used to do rotator cuff surgery when it was open, big incision, and ACL surgery as inpatients. So patients never did outpatient. Now, no one will have rotator cuff surgery or ACL surgery as an inpatient. I suspect towards the end of my career, probably close to 20 to 30% of my practice for joint replacement surgery will be done outpatient because of the improvements in technology and ability to control people's pain, nausea, and there's nothing like sleeping in the comforts of your own home in bed and then somebody waking up at 4 o'clock in the morning to check your blood pressure and draw blood from you. That's not needed. The other things that I would say also is that 90% of patients wait too long to consider surgery, mostly due to misinformation. And that's one of the reasons why I'm here, is to inform you of options. You should always have options, always have choices when deciding how to manage your knee pain or knee problem. Next. So my treatment rationale, one of the things that I should tell you is that I do not, I'm not a consultant to any company. I've used probably 5, actually now 6 different companies in my career, and I use the company that I think has the best product, on the planet. And I never, liked when I first started using computer surgery back in 2007. I was using a different company called Pew. It had a rotating platform knee. My results were about 85 to 88% good, excellent, but there was always a certain percentage of people that still weren't happy with their knee. And they would still have problems going downstairs. They'd always feel like the knee's gonna buckle every now and then, or feel a little bit unstable. And every now and then their knee would still make noises. And they were like, gosh, why is it snap, crackle, pop, snap, crackle, pop? And I thought you took all the arthritis out of my knee. And I was finding out that a lot of my patients, when I examined them, when I bent their knee to about 45 degrees, I could really move their knee quite a bit. And it was because I really felt it wasn't because of the way I put in the knee, because I'm putting the knee in with a degree of accuracy using the computer. I really felt it had to be something with the prosthesis, that it wasn't designed right. And it wasn't until 2009 that I met with the Stryker rep, and they said, well, we have a new design knee that's a roundabout knee, it's round. So the ligaments stay nice and it's the same length to a full arc motion. I said, boy, that makes intuitive sense to me. But before I use your knee implant, because I've heard this before, just because it's new doesn't mean it's better. They brought out one of the engineers that designed the implant from Scotland and came to Hampton Roads and met with me and explained the design rationale. Well, it was like a light bulb went on. I said, I wish I was smart enough to design an implant like this, but this finally was the first implant that made the most sense to me. And I told the rep at that time that I would do 5 knees if those patients do really well. I'll do 25 knees, and if they do really well, you have my business. And after doing about 150 knees my first year using that company in 2009, 2010, my partners saw my patients doing incredibly well, not having some of the problems that they were running into. They all switched to using Stryker and Stryker knees, so our entire practice, which is unheard of in orthopedics, all use Stryker knees and knee replacements for that reason. And then to take it one level further, I always said, gosh, we use press fit designs in the hip, which means we don't use cement a lot of times in the hips anymore. It's a faster operation. Patients do well. There's less pain because you're in the operating room less time. You're less hogging on the muscles and pulling them apart to do the surgery. I said it makes sense. Well, why not have that in the knee? So what was it, about 4 years ago? Would you say, Mike? About 4 years ago, I said, okay, I'll try the press fit design in the knee, which is basically a type of design that the undersurface of the metal implant looks like honeycombs. It looks like metal honeycombs, for lack of better words, and the bone thinks it's bone. So what does the bone do? Your bone's living tissue, it grows into it and fixes and adheres to the thing. The nice thing about that is, it's kind of like the analogy that I give with tile. If you ever tile the floor and you put grout down to keep the tile in place, there's two bonds. There's a bond between the grout and the tile, and there's a bond between the grout and the floor below it. Well, there's two areas now that bond can be broken to potentially make the tile loose. The tile gets loose, what do you have to do oftentimes? Sometimes replace the entire floor, because you get a new tile, it doesn't match, doesn't fit. You have to take all the grout up, redo the whole thing. Well, that's the equivalent of knee replacement surgery. When you talk about knee replacements failing, the most common reason for it to fail is something that we call aseptic loosening, the bond between the cement and the bone, or the bond between the cement and the metal breaks, and it becomes loose. And becomes loose, it becomes painful to the patient, and then they need to have it revised. And that's why oftentimes we say sometimes knees only last 15 to 20 years and you have to have them revised because it becomes loose. But imagine if you have tile where you have grass that can grow into the tile and hold that tile in place. And imagine if that tile becomes loose because of an injury or fall, or you hit it the wrong way, but that grass then can grow right back into it and fix that tile. That's kind of the analogy with this new implant. And I've had now 2 cases in the past 4 years where I've had patients fall, actually almost break part of their bone, and I managed them non-operatively. I didn't go back in, and their bone moved back into the implant and saved them from having another operation. And they did really well. So this is the closest to what I consider to be the best artificial knee you can have. I think that I won't see it in my lifetime, but I think the best knee you can have is being able to regenerate your own cartilage and have your knee restored. I don't think I'll see that in my lifetime. That would be the ideal. And the reason for that is because a normal knee has 50 times better frictionless surface than any artificial made surface. We can't design any surface as good as knee cartilage. It's impossible, humanly impossible right now. Some of the things that we have done that I think have made a big difference is preemptive anesthesia. You may have heard of this. Preemptive anesthesia means having your leg numbed up before I even start doing the surgery. You take away the pain before you start the pain. And that has really made a big difference, and one of the reasons why we can do same-day surgery. I also use long-acting numbing medicine locally in the tissues called Exparel, also with marking, and that I found to be very effective also, which then decreases the need for narcotic use after the surgery. You take a lot of narcotics, you feel loopy, you feel drunk, you don't feel like getting up and walking and moving. But when your mind is clear, you say, boy, I want to get better, I want to get up, I want to get moving. You get moving faster, you get going faster, people do better. I talked about the 17 plus true outpatient total knee replacements since November 2016, and they're still doing better. One of the nice things that I didn't even mention is the cost savings by doing an outpatient. It saves Medicare and Medicaid or any insurance company around $30,000 to $40,000 by doing outpatient. Well, that would be huge, considering that we're doing hundreds of thousands of new knee replacements every year in the United States. So anybody who's a CPA out there can probably do the math better than I can, but it will save millions, hundreds of millions of dollars potentially long term. Okay, next. So one of the things that I have to say, this slide's boasting a little bit of our scores, but this is very accurate. One of the things that we're very proud of is we do have one of the top 100 orthopedic programs in the United States, and that's Becker, which is an outside agency that ranks orthopedic programs. Health grades, maybe some of you have gone on health grades or looked at health grades online when you go to a hospital, rate a doctor. One of the things that we're very happy about is that we're in the top 2% of the country and the only one in the Hampton Roads area that's rated in the top 100 best hospitals. We have one of the lowest infection rates for total joints since 2010. Our infection rate has been 0.1%. The national average is 1%, 1 in 100 people get infected nationally. We have 1 in 1,000. I'd love to say it was 0. It was 0 for a while, but we did have 2 infections over the past 9 years. So ours is less than 0.1%. We do have one of the lowest lengths of stay in the region, and that means people are doing well and doing well enough to get out of the hospital much faster because of some of the things we just talked about. And the HCAP scores basically are scores that anybody who has a joint replacement, the government will send you a survey to fill out. When people fill out that survey, they rank what they perceive to how good their knee or hip is functioning. And right now, we've been in the top 1% for the past 3 years from our patients rating us this. So this is not the doctor rating it, it's the patient rating it. For example, I rated that patient that I told you about earlier that only has 0 to 90 degrees range of motion as poor. He rated his knee as excellent. So I rated it as poor because he didn't get to 120 degrees. But that's being objective. To him, subjectively, the knee's great. It's not painful, and he's got great range of motion. For him. Next slide. Okay, that's it. I think that for the rest of this talk, I'd really like to open it up to everybody who has questions, and I'll try to repeat the question so if some people didn't hear it, everybody can hear the question.